Today we have another lecture. The topic is myocarditis. It is by Dr. Tilak Sirisena. He's a consultant cardiologist working in Australia, in Dubbo, Western Australia. New South Wales in Dubbo. It's around 12:30 in midnight for him, so you can understand how difficult it is for him to arrange time and give us this lecture. He's a graduate of the Medical Faculty Colombo, passed out in 1998 and got his MD in 2004. He had his board certification as a consultant cardiologist in 2008. He has worked in many parts of Sri Lanka, including Anuradhapura, Kurunegala, Kandy, and Colombo. He is a fellow of the Royal Australian College of Physicians and fellow of the Cardiac Society of Australia and New Zealand, and also a member of the Sri Lanka Heart Association. So he has been a very hardworking cardiologist. I think we missed him. The whole country misses him. We'll see. Maybe someday he will come back. So over to you, Tilak.
Thank you, Guru. I think hope you all can hear me well. So today's topic is myocarditis. This is a little bit of a boring topic, but I'll try to sort of make it simple as much as possible. So we'll try to sort of cover a definition, clinical presentation, and epidemiology of myocarditis in our first few slides. And then what investigations we should do. Especially, we will talk a little bit more about a place of myocardial biopsy versus cardiac MRI. And then towards the middle, we will talk about various forms of myocarditis. And then at the end, treatment and prognosis. And I'm happy to take questions after that, if there are any questions. We will start with a clinical case. Now, this is a patient that I saw now about 3 years ago. I think this is the third year that I'm doing this talk. So, this story is a little bit old now. So this is a 40-year-old woman who came to our hospital in March 2022, having woken up with ischemic sounding chest pain. On presentation to the emergency department, she had, as you see, ECG changes, T-wave inversions in inferior and lateral leads, and had very high troponin T levels, troponin I levels. I'm sorry. And now this is this is high sensitive troponin measured in nanograms per liter, and she had about 50,000 troponin level. The bedside echocardiogram was performed, and it was normal apart from mild mitral regurgitation. D-dimers were done. They were negative, and this is the height of COVID. So the COVID PCR was also negative. I think with this story, I think it is clear that this is a presentation of most likely a non-ST elevation myocardial infarction with chest pain, ECG changes, and positive troponin. So it qualifies, presentation qualifies all three criteria. But other differential diagnoses include pulmonary embolism, myocarditis, Takotsubo's cardiomyopathy, and then in a young female, a spontaneous coronary artery dissection, which is, of course, a form of a non-STEMI. When you go to a past medical history, she had history of recurrent myocarditis. She had already had 2 presentations in March 2021 and June 2021. She had coronary artery disease excluded with a normal CT coronary angiogram and 0 calcium score. She had already had a cardiac MRI, which had shown some features of resolved in myocarditis. She had other investigations performed to look at the etiology of myocarditis, including autoimmune panel, viral panel, CT, chest, abdomen, and she had been already treated with colchicine and prednisolone. Now, with this history, I think you would agree that the most likely diagnosis for this woman, for this presentation, is going to be myocarditis. We changed that that diagnosis really because of the past medical history of recurrent myocarditis. So one of the things that you will realize by this story is that myocarditis is not not a disease of exclusion. Now we used to think that we exclude every other thing to diagnose myocarditis, but that is not the case. We can diagnose myocarditis positively straight sometimes. Then what do you do next? We will keep this to the end of the presentation. It will be easy for you to answer at the end. So what is myocarditis? So as the name implies, it's an inflammatory condition of the myocardium. That is myocardium. Itis means inflammation. Now, this is diagnosed by histological, immunological, and immunohistochemical criteria. So it's basically for you to diagnose definite myocarditis, you need to have a biopsy from the heart, or which is called endomyocardial biopsy. That is for the definitive diagnosis. And then you have this Dallas criteria for histology, and then there's European Society of Cardiology histochemical criteria, as you would see in the slide. How common is myocarditis? It's not very common. The global incidence is about 1 to 10 per 100,000 persons per year. This came to the spotlight because of COVID-19 infection. There were a lot of media coverage of myocarditis being caused by COVID-19 and also COVID-19 vaccines. The highest risk was seen among the men, young men between 20 to 40 years. If you take heart failure patients, about 0.5 to 4% of these heart failure patients, acute heart failure patients, are due to myocarditis. About 3% patients who are coming to the emergency department with chest pain has myopericarditis. If somebody came with an acute coronary syndrome and had a normal coronary angiogram, they are called MINOCA patients, myocardial infarction with normal coronary arteries, non-obstructive coronary artery disease. 1/3 of them would have myocarditis. So, and then about 10 to 12% of people who die suddenly also will die from myocarditis. Immune checkpoint inhibitors are they are used in cancer treatment. There's about 1% of these people can develop myocarditis. And as you can see from this, the myocarditis is common with or more common with COVID-19 infection than vaccines. So there are many causes for myocarditis, as you will see in this slide. So you can broadly classify into infectious causes, immune-mediated causes, and toxic causes. Now, out of the infectious causes, the viral causes are the commonest. Viral myocarditis is the commonest. Now, any flu-like viruses like influenza A, B, respiratory syncytial virus can cause myocarditis. Now, maybe chikungunya virus may be relevant to Sri Lanka now, because I heard there's a big outbreak of chikungunya, and then dengue as well. And then spirochetal leptospirosis can cause myocarditis. We have seen that. And then out of the immune-mediated myocarditis, all the autoimmune diseases like systemic lupus erythematosus, rheumatoid arthritis can cause myocarditis, rheumatic fever. As you know, rheumatic carditis is a pancarditis, which can cause myocarditis. Sarcoidosis, we are going to talk about a little bit of sarcoidosis. I have not seen a person, people with sarcoidosis in Sri Lanka, but it's quite common here. And then out of the toxic myocarditis, some of the medications can cause myocarditis. The prescribed medications like clozapine, which is used for schizophrenia, treatment of schizophrenia, and then this trastuzumab, which is commonly known as Herceptin, which is an anti-cancer medication to treat breast cancer, can cause myocarditis. And recreational drugs like amphetamines, or commonly used known as ice, which is a very common issue here. Cocaine and also alcohol can cause myocarditis. And also snake bites, we should not forget. So there are many causes for myocarditis. So when you investigate, I think it depends on where you live, and then you investigate for common causes. So viral myocarditis, the problem here is some of these viruses, like adenoviruses, parvovirus, enteroviruses, and these can be very common. So as you learn later, just presence of the antibodies in the blood does not mean that that is the reason for the myocarditis. But these things like cardiotoxic viruses like hepatitis C, HIV, their presence actually can signify that it could be the reason for the myocarditis. And you can see the coronavirus is also an important cause. So if you think about or take viral myocarditis, it undergoes these three phases. Acute phase, where the virus enters into the myocardium and then replicate. Then in the subacute phase, you get the immune-mediated response, where the antibodies are formed against the viruses, and then the cellular infiltration can happen due to the immune response. And then the chronic phase, when the myocarditis can precipitate to form a dilated cardiomyopathy. Clinical presentation, the commonest sign or commonest symptom of myocarditis is chest pain. So that is why it becomes a differential diagnosis for acute coronary syndrome. Some people can present with shortness of breath, and then small number of people can present with syncope or pre-syncope. Most people will have an uncomplicated course, about 75% of people, so it will go unnoticed, or you may even not diagnose. About quarter of people can develop acute heart failure and arrhythmias, and then a very small number of people can really become hemodynamically unstable and die. So myocarditis can present in all these ways that is mentioned here. So they can come with troponin negative chest pain and troponin positive chest pain. Now that's a little bit of a problem, especially when the troponin is negative. You would think that chest pain could be something else and not coming from the heart. So, but it can present with troponin negative chest pain, and negative troponin does not exclude myocarditis. So you need to consider the other parameters like, the ECG, echo, cardiac MRI, and things like that. They can also present with acute heart failure, syncope, sudden cardiac death, tachy and bradyarrhythmias, and cardiogenic shock. So what investigations we do to diagnose myocarditis? So basically, diagnosis relies on multiple sources of data. It's not just one investigation that you do to diagnose myocarditis. If you can do one, it would be endomyocardial biopsy, which is not readily available, and it is a difficult procedure to do. We'll talk about it later, and it is not readily available, and it's invasive. So therefore, we rarely do endomyocardial biopsy to diagnose myocarditis unless there are specific indications for that. European Society of Cardiology recommends a non-invasive diagnostic workup, which we are going to talk about in a minute, and that will help us to establish what is called clinically suspected myocarditis. So that is good enough most of the time for us to diagnose and treat. So clinically suspected myocarditis diagnosis depends on two main criteria. Now, the first one is the clinical presentation, the top, and then the other one is the investigations. So if the patient is symptomatic, you can have either one of the clinical presentation and one of the investigations positive, one from each. Then you can diagnose clinically suspected myocarditis. If the patient is asymptomatic, then you need to have two of these diagnostic investigations. So clinical presentation, as you will see here, mostly it is acute chest pain, pericarditic chest pain. You know what that means. The pain increases with breathing and classically get worse when the patient lies down and get relieved when the patient sits up. And then new onset shortness of breath within 3 months, with or without signs of heart failure, or subacute or chronic shortness of breath more than 3 months, again with or without signs of heart failure. Then symptoms of arrhythmia like palpitations, pre-syncope or syncope, and then unexplained cardiogenic shock. So those are the things that we discussed. And then the diagnostic criteria, we use ECG, almost any ECG features like STT changes, heart blocks or tachyarrhythmias, elevated troponins, TOI, then the 2D echocardiogram and cardiac MRI findings, and then so those things will help to make the clinically suspected myocarditis, and we will go through these things in detail. At the same time, the patient should not have coronary artery disease or any pre-existing cardiac or extracardiac causes to cause this presentation. So if somebody comes with or chest pain, if you suspect myocarditis, I think one of the first things you do is to do an ECG, which is very readily available. Anyone can do ECG if you have a machine, and therefore it should be performed in all patients who are suspected to have myocarditis. The cardiac monitoring with the telemetry should be performed in patients with positive troponin, LV dysfunction, or arrhythmia. That's standard acute coronary syndrome pathway. More than 50% people will have abnormal ECG. It can mimic a ST elevation myocardial infarction. ST elevations can occur because of myocarditis, and also any heart block, second degree, third degree, or ventricular tachycardia can happen. And if they happen, they are bad prognostic sign. And then ventricular tachycardia, polymorphic ventricular tachycardia happens in acute myocarditis commonly. and that is, and then monomorphic ventricular tachycardia happens in chronic myocarditis. So if you suspect myocarditis, again, we should try and perform a echocardiogram almost in all patients. However, about a majority of people will have a normal LV systolic function on the echocardiogram. So if you have a normal LV function on echocardiogram, that's actually a good prognostic sign. So on echocardiogram, you can see all these things, one or more. You can see LV systolic dysfunction, LV diastolic dysfunction. You can see regional wall motion abnormalities. Now, generally, myocarditis is thought to be a global dysfunction, but rarely you can have regional wall motion abnormal or regional dysfunction as well. Now, regional dysfunction is classically seen in coronary artery disease because it depends on the blood supply. Pericardial effusion can be a feature, especially if the pericardium is also involved. Then we call it we call it either myopericarditis or perimyocarditis. And then if you do what is called GLS or global longitudinal strain, you will see the reduced global longitudinal strain. You might see edema in the left end, the muscle wall, making it increasingly thicken. So all these things can be seen on echocardiogram. One of the first things we need to do is to exclude coronary artery disease, especially if someone is coming with chest pain and ECG changes and positive troponin. So it is important to exclude acute coronary syndrome, but it depends on so with whom you need to do a coronary angiogram. It depends on the patient's age and the presence of cardiovascular risk factors. So, for example, if somebody like if a 20-year-old or patient coming with this presentation, you don't need to necessarily do a coronary angiogram because you know that the pre-test probability of having coronary heart disease is very less. But if the patient is about 45 years, if the patient has other cardiovascular risk factors, or if the ECG echo showed a possibility of a vascular issue like regional wall motion abnormalities or STT changes in the regional setting, then you need to do a coronary angiogram. You can do either an invasive coronary angiogram or a CT coronary angiogram, depending on the case. Then we also do a lot of blood investigations. Again, if you look at that list that I showed you, there are a lot of things that you can do, but it depends on where you live and how common these conditions are in your region. But these are the things that we generally do almost in every patient. You do a full blood count. It's important to look at the eosinophilic count. Peripheral eosinophilic count on the full blood count. Eosinophilic myocarditis is quite a dangerous situation. Liver renal functions, thyroid and iron studies, ESR and CRP, they are generally elevated, but normal results do not exclude myocarditis. Troponin INT, we talk about NT-proBNP levels, screening for autoimmune disease. Viral serology, not routinely recommended. The reason is that just presence of viral antibody does not always mean that it is the reason for the myocarditis, because viral antibodies are so commonly found on the blood. Apart from hepatitis, HIV, and these other things, rarely we also need to do genetic testing, which I will briefly touch upon. Apart from all these, sometimes we do a PET scan, especially if you suspect sarcoidosis. So we do what's called FDG, or fluid deoxyglucose PET scan to diagnose sarcoidosis. So as we mentioned that the myocarditis is definitely diagnosed by an endomyocardial biopsy. So what is endomyocardial biopsy? So what you do is you take a piece from the myocardium. It's mostly from the right ventricle. So we put this catheter called bioptome from the internal jugular vein in the neck, pass this to the trust the tricuspid valve to the right ventricle, and then we take a piece from not from one area, maybe more than one to six areas in the septum around this area, and then send it to the laboratory to do the histology. So as I mentioned earlier, it's an invasive procedure. It's not very commonly available, and has a fair complication rate, including cardiac pericardial effusion and cardiac tamponade, arrhythmias, heart blocks. But in centers where these things are done very commonly, it's not an unsafe procedure. So who needs endomyocardial biopsy? And so we discussed that we don't do it in everybody. So basically, if somebody is suspected to have myocarditis and they are really unwell with these conditions, which are in this red box, if they are hemodynamically unstable, if they are having a second degree or third degree heart blocks, or if they are having sustained symptomatic ventricular tachycardia, and the recent of onset is less than 4 weeks, and these people will need endomyocardial biopsy as a first line, because it is very important to diagnose the histology. And this is going to be because these people will most likely benefit from immunosuppressive therapy. If the patient has no such symptoms and the patient is stable, then the first line would be a cardiac MRI, which is also not readily available in here in where I work. But I think it's in Sri Lanka. It is available. And then if the cardiac MRI shows up these features like more than mild LV dysfunction, or when we monitor the patient in the CCU, the patient develops arrhythmias, if there's a peripheral eosinophilia, and if the patient has been treated with this immune checkpoint inhibitors, then you need to have a cardiac biopsy. So basically in this, so we discussed these patients who are hemodynamically unstable, actually they're less than 5% of the people. So those are the people who will straight away need a cardiac biopsy to diagnose myocarditis. I'm not going to go through this slide. This is the current criteria for indications for endomyocardial biopsy. You can read it if you want. But what you need to understand is that negative endomyocardial biopsy does not exclude myocarditis, because it depends on where you take the sample from. The myocarditis can be patchy. So if you take the sample from a healthy area, you won't see anything. And then when you take it also, so if you need to have a highest utility, you have to do it within first 2 to 3 weeks of having symptoms. And then there are many other things which can affect the success or yield of the myocardial biopsy. So basically, if the other things fit, negative endomyocardial biopsy does not exclude myocarditis. So these are the things which can diagnose from myocarditis, and they all of these will have actually very bad outcome. So these people can actually become unstable and then and die. So that is why it is important to do a biopsy and histology early. Right? So like cardiac sarcoidosis, giant cell myocarditis, eosinophilic myocarditis. And then you can do other viral studies as well. So who needs the cardiac MRI? So they are all other people who are hemodynamically stable, which is the majority of the people. Will need a cardiac MRI to diagnose myocarditis. So basically, so these are the things you look at in the cardiac MRI. There's the thing called T1 weighted images. It will see the fatty tissue. T2 weighted images look at the water. I remember this as World War II. So World WW2. So World WW for water, 2 for T2. So when you do the T2 weighted images, you actually see edema. Then you have this what is called late gadolinium enhancement. Gadolinium is a contrast that they use, and late gadolinium and early gadolinium enhancement. And late gadolinium enhancement actually see a presence of a necrosis or scar, basically necrosis or fibrosis. And depending on the pattern of this late gadolinium enhancement, you can actually see whether the troponin rise was due to ischemia or non-ischemia, like something like myocarditis. So if it is ischemia, you actually see endocardial. You can see here endocardial late gadolinium enhancement. In ischemia, the endocardium affects more than earlier than the pericardium or the outer layer. If it's a transmural or endocardial, subendocardial, it is ischemia. In non-ischemia, it's subepicardial, so at the periphery, like that. So that's important thing. One important thing to that you can differentiate ischemia versus non-ischemia. And then we don't need to go through all this, but there is this set of criteria called Lake-Lewis criteria that the radiologists use to diagnose myocarditis on a cardiac MRI. So these criteria were updated in 2018 with better sensitivity and specificity compared to the original criteria, which was established in 2009. So it is important to remember this name, but I don't think you need to remember all that. Then we will briefly, or probably not briefly, a little bit in detail, talk about various forms of myocarditis in which the situations that you encounter myocarditis. So in countries like us, we see a lot of rheumatic carditis. Rheumatic carditis is pancarditis. You can have endocarditis, myocarditis, and pericarditis, but it's mainly endocarditis or valvulitis, as you know. But myocarditis can happen in about quarter of people, but it goes usually unrecognized. Chagas disease is not commonly seen in Sri Lanka. It's seen mainly in Central and South America. That can cause myocarditis, and dengue is very common. And we have seen myocarditis associated with dengue. Yes. Yeah, COVID-19 is the one which actually gave myocarditis a lot of publicity. But with the COVID-19, it is not a common thing, myocarditis. But so myocarditis was common and bad when the patient is actually bad from concomitant pneumonia than those without pneumonia. And then this is the big problem. Some of the vaccines actually cause myocarditis. We had encountered people who developed myocarditis after the vaccine, which is not common, and it actually it was seen with both Pfizer and Moderna vaccines, and it was common in young men within few days of the second dose and usually self-limited. I can remember for one person we gave prednisolone. Many others actually we did not do anything. Immune checkpoint inhibitors, yeah, it's mainly you encounter this in cardio oncology, and these immune checkpoint inhibitors are used to treat various cancers. Now, because I did this presentation to our people here, I included this. But what you need to remember is that these people can actually develop myocarditis, especially in the early in their treatment. And immune checkpoint inhibitor myocarditis has a very high mortality. So it is very important that you diagnose this early and treat early. And then European Society of Cardiology and other colleges have actually made a set up diagnostic criteria, and also how to sort of monitor these people when they are on treatment to diagnose myocarditis. Cardiac sarcoidosis is also a form of myocarditis, which has a very bad prognosis if you do not identify this and treat this. But in Sri Lanka, it is very uncommon. I have not seen a patient with sarcoidosis in Sri Lanka, a cardiac sarcoidosis. But we see few people with sarcoidosis here. So basically, the cardiac involvement can occur in about 5% of people who are already having pulmonary or systemic sarcoidosis. Isolated cardiac sarcoidosis occur up to 25% of cases, and they present with either conduction abnormalities or heart failure, and they are at high risk of having a sudden cardiac death. So as you can see here, about 35% of patients with complete heart block, and if they're younger than 60 years. So in a young person, if you see a conduction abnormality, and if the sarcoidosis is prevalent in your area or in your country, then you have to think about sarcoidosis. And then about 28% of patients with ventricular tachycardia of unknown cause also may have underlying sarcoidosis. And as I said, the PET scan is a good scan. If fluorodeoxyglucose PET scan is a good way of diagnosing sarcoidosis. Cardiac MRI is also helpful, and then definitive diagnosis is made by doing a biopsy. If the patient is already having a extra cardiac sarcoidosis, it is easy to diagnose. If the patient has no extra cardiac sarcoidosis, it's a bit difficult, but you might need to get a cardiac biopsy. So there's a diagnostic criteria for cardiac sarcoidosis. As I said, if the patient has under this two here, the patient has already diagnosed extracardiac sarcoidosis. If any of these things happen, like then you need to think about cardiac sarcoidosis. So these are the unexplained heart failure, tachycardia basically. Genetically, there are genetical causes for myocarditis. So these are called desmosomal gene variants. So the desmosomes are the ones which actually they keep the cells bound together. They are the ligands between the cells. So they maintain the structural integrity of the tissues, right? So So these are produced by the genes, and in some people you have the mutations of these genes, and then actually as a result, because you lose the integrity of the myocardial cells, you develop myocardial damage or basically myocarditis. And this is a very rare condition, but generally it's common in females, and they give a history of previous myocarditis in our patient. There's a family history of myocarditis too, because it's a genetically determined disorder. The MRI, if you do, there are specific features of MRI. Based on that, you can actually suspect that this could be a genetical variant. The most dangerous thing is that actually they are more prone to develop ventricular tachyarrhythmias. So therefore they can actually die suddenly of the ventricular tachyarrhythmias. So that is why it is important to think about it, especially in a person who has recurrent myocarditis and also has a family history of myocarditis. Fulminant myocarditis so you call myocarditis as fulminant when the myocarditis is severe and of recent onset. So basically a patient with fulminant myocarditis will present and become hemodynamically unstable within days. So what will happen is, so they will drop their blood pressure, which you could not be managed with the usual vasopressor support. And if this happens, the mortality becomes 50% or more. So it is very important to diagnose fulminant myocarditis. So these are the people who are going to die of myocarditis. Now we have heard this time to time that people have died because of myocarditis. Now these are the category of people who are going to die. So they will come and they will become quickly deteriorated, and then the LV function drop. You cannot maintain the blood pressure and the circulation, and they die. And don't worry about this. But so basically, they say it is because of a cytokine storm. And fulminant myocarditis again is common in these situations that I told you earlier, like giant cell myocarditis, eosinophilic myocarditis, lymphocytic myocarditis, or granulomatous myocarditis, like in sarcoidosis. So these are the people. That is why I told earlier that if they are hemodynamically unstable, that is why the cardiac biopsy is recommended, so you know exactly what's going on. So they will develop a cardiogenic shock very quickly. They will need inotropic and vasopressor support. If there's no response to inotropic and vasopressor support, then you need to consider mechanical circulatory support very quickly, like ECMO or intra-aortic balloon pump. Intra-aortic balloon pump is commonly available. ECMO is limited. And then Impella is again is a cardiac device which will maintain the circulation. And on mechanical support, if you cannot wean off the patient from that, then you are talking about urgent heart transplant or a left ventricular assist device. But some of these conditions, if you even do the heart transplant, sometimes the transplanted heart can develop myocarditis if there's an underlying condition like cardiac sarcoidosis or giant cell myocarditis, rarely. So basically, management of fulminant myocarditis include early diagnosis and early intervention. right? So you have a coronary angiogram here, exclude coronary disease, and then depending on the problem, if there's a breathing problem, you actually do non-invasive ventilation with BiPAP, and then invasive ventilation. If the patient goes into renal failure, then think about dialysis. If the patient is in shock, then think about the mechanical support. And at the same time, then you start treating the underlying cause with immunomodulation or immunosuppression. Then what are the bad prognostic signs? I think we actually talk about them. So as I said, the mortality is about 1 to 7%. So most people will have uncomplicated course and probably go unnoticed. But if you have features like this, if their LV function is low, if they develop severe heart failure, advanced AV blocks of sustained ventricular arrhythmias or cardiac shock, they are in a bad form. These are the bad prognostic signs. And on histology, if you have giant cell myocarditis or eosinophilic myocarditis or cardiac sarcoidosis, they also have a bad prognosis. And if they have ventricular tachycardia or a lot of fibrosis on the cardiac MRI, and then, as I said, these desmosomal gene variants, they are more prone to develop sudden cardiac ventricular tachycardia and sudden cardiac death. So these people may need prophylactic AICD or implantable cardioverter defibrillator implantation. So the risk stratification, you can basically, when you see a myocarditis patient, you can say whether the patient is high risk or low risk or intermediate risk. So high risk people are the people who are in shock or having symptoms of acute heart failure. Their ejection fraction is very low on the echocardiogram, less than 30% or 30 to 40%, and then on the telemetry they have VT, VF, or advanced AV block. So these people are the people who can die. So it's very important that you identify this category of people. They are rare. They are maybe less than 5%. Then if you are in a peripheral hospital, you get them to a major hospital very quickly. Then, where they can consider doing all this temporary pacing, mechanical circulatory support, and immunosuppression. And they will also consider doing MRI and the biopsy. The low risk people are the no symptoms of acute heart failure, and their ejection fraction is normal on the echocardiogram, and they don't have any cardiac arrhythmias. And these people probably can be managed even in a peripheral setting. And then you have the intermediate risk profile. So treatment, so the low risk people is generally, conservative management. We use, as if the patient is having pain and especially has evidence of pericarditis, we use NSAIDs, aspirin and colchicine. If the patient is high risk or intermediate to high risk, they will be referred to a tertiary care center. If the patient is in heart failure, we give standard heart failure therapy like beta blockers, ACE inhibitors, spironolactone. Then if the patient has a heart block, then consider a temporary and also temporary pacing. And then if the patient has all these conditions which make them high risk of developing ventricular tachycardias, and then maybe AICD. And then depending on the underlying reason, cause, then you immunosuppress them. Not everybody, but if they have these conditions, the patient is having systemic autoimmune disease, then steroids are the first line treatment. Then second line, you can use cyclophosphamide, mycophenolate mofetil. Immune checkpoint inhibitor induced myocarditis, then again the steroids. First line, giant cell myocarditis, again steroids. Cardiac psychosis, steroids, and then second line, either methotrexate or azathioprine. Eosinophilic myocarditis, corticosteroids, first line treatment. Lymphocytic myocarditis, there are no big evidence. So some recommend steroids, some not. I think the biggest question is the follow-up, because myocarditis usually happen in, as I said, in young people, and it can actually affect their daily routine a lot. So the patient could be somebody who is participating in competitive sports, or going to a gym every day and doing intense physical activities. But it is important that we restrict these physical activities at least for 3 to 6 months, and then do a proper assessment at 6 months with a 12-lead ECG, troponin levels, echocardiogram, and a Holter, and maybe if it's available, with a follow-up MRI, and also a treadmill test. Make sure that there's no ongoing myocarditis and the patient has recovered very well. So this is a paper from Jack some time ago in a center in USA. This is what they do. So they suspect all the play until resolution of clinical symptoms. They wait 6 to 8 weeks, 3 months if the patient has heart failure. And then at the end, they do a repeat imaging and a cardiac MRI, then do a functional test, including a stress test, and also at least a 1 week of ambulatory ECG, like a Holter for 1 week. And if there's no arrhythmias and the patient has a good exercise tolerance, a patient is allowed to return to play. So basically, so that is it. And this is what happened to our patient. So this patient that I presented actually had, you may remember that this patient had recurrent myocarditis, is a young female. She did not have a family history of myocarditis, but she was later found to have a genetic variant or desmosomal gene variant associated myocarditis. That's it. I'm happy to take any questions you will ask. I don't know whether you do the MCQ now. I can't remember.
Hello.
Hi, Guru.
Yes. You can discuss the two questions also if you have time.
Yeah. So it's straightforward. So the first MCQ is which statement is true regarding the diagnosis of myocarditis? So the first statement, the majority of patients have LV systolic dysfunction on the 2D echocardiogram, which is obviously false. We said that 75% of people will have normal LV function. The negative endomyocardial biopsy can exclude the diagnosis. So that's also false, because myocarditis can be patchy. And if you take a biopsy from a normal healthy tissue, you won't see anything. And also it depends on when you are going to take the biopsy. So Basically, negative endocardium biopsy does not exclude diagnosis. Viral serology is not routinely recommended. Reason is that viral infections are so common, and just presence of antibodies in the blood does not mean it is the reason for the myocarditis. You need to actually look at the tissue, and count the number of genomes of the virus, and satisfy a certain number before you attribute the virus to the myocarditis in most cases. Negative troponin exclude diagnosis, which is again false, because we discussed that troponin can be negative in certain forms of myocarditis, especially in giant cell myocarditis, and also it depends on when you take your troponins. Um, Cardiac MRI has high sensitivity and specificity performed within 2 to 3 weeks of the onset of symptoms is correct answer. And if you want to do a cardiac MRI, this is the time that you need to do. If you delay it, then the utility becomes low. So the answer is number 5. Which statement is false regarding myocarditis? Routine treatment with steroid is not evidence-based. Yeah, we said that we don't treat myocarditis routinely with steroids. That's true. Therefore, mechanical circulatory support improves outcomes in cardiogenic shock associated myocarditis is also true. Especially if you cannot maintain the circulation with the inotropes and vasopressor support alone, you need to consider mechanical circulatory support early. That will definitely improve outcomes in these people. Participation of competitive sports is not recommended during the first 6 months after the diagnosis of myocarditis. That is correct. And also at the end of the 6 months, the patient should undergo a detailed proper assessment, including repeating imaging, doing a functional test, and also a Holter to exclude arrhythmias before they are allowed to participate in competitive sports. Number 4, ACE inhibitors and beta blockers improve outcomes in heart failure associated with myocarditis. Yes, it's generally all the routine heart failure medications improve outcomes in heart failure because of myocarditis. So it is true. Immunosuppressive therapy is contraindicated in myocarditis due to cardiac sarcoidosis is the false answer. So if you diagnose sarcoidosis, you need to give them steroids and immunosuppressive therapy early to treat sarcoidosis induced myocarditis. So the answer is again 5. Thank you.
Thank you, Tilak. Thank you very much for that excellent lecture and the discussion. If anyone has any question, they can either put it in the chat or put it in the chat or can directly ask. Any questions? I think they are more concerned about your time.
That's all right. No, that's my time is now 1:38. Yeah.
1:38. Yeah. I think, since there are no questions, we will conclude.
And there's one question. I don't know. Can you read that? Thank you.
Thank you.
Thank you. It's not a question. Okay.
So we will conclude the lecture. Thank you very much, Tilak, for your time. I hope you will continue to support the program in the coming years. I hope somebody else will take over and do the program from next year onwards. I may not be continuing, but hope you will continue to support the program. Thank you very much, and hoping to see you when you visit Sri Lanka.
All right. Thanks, Guru. Have a